Okay. Hemorrhagic strokes, 25% of strokes, caused by when a artery or a vein has a leak, has a weak wall in it, and that weak wall will tend to pooch out, and that is what the aneurysm is. That's what an aneurysm is a ballooning out of an arterial or venous wall, and and eventually it will become weaker and weaker, kind of like a balloon getting stretched and stretched as more blood fills into it, and then it'll burst, and then you have a hemorrhagic stroke, and then blood is freely flowing into your brain, and that's no bueno. So you can have bleeding that is within the brain, and that's called an intracerebral hemorrhage. And then you can have bleeding, the meninges that form on top of your brain and spinal cord. You can have a stroke between those layers, the little bitty arteries, and those are called like subarachnoid strokes if it's under the arachnoid layer, or it can be called a subdural stroke or hematoma if it's under the dura. There's another type of stroke that is it is a hemorrhagic stroke, but it's a very special type and it's very scary. And this kind, you can only be born with it. It's called an AVM for short, or arterial venous malformation. And basically what it is like this, and it's congenital, and you're born with it, and your arteries and your veins inside your brain while you're in utero and forming, they don't form right. So they form into this twisted, almost think of like when you pull out like a thing of Christmas lights every year out of the box and they're all tangled up, and you just hold them up and they're just a big tangle and it looks like it's impossible to straighten them out. Well, that's the arteries and veins, how tangled up they are together in an AVM. You go through life with one of these, and you may never know you have one of these. I've had, when I was working at Tier inpatient, I had several patients in their 20s that were just regular, normal 20-year-olds. One was in college, the other two were out of college, just starting their career, and they had AVMs that ruptured, and nobody ever knew about it because they never had any symptoms, they never had any headaches from it, they never had any symptoms or signs. So they only found out about it when they ruptured. And then they had massive strokes because of the way their blood vessels were formed, and they had to go through a lot of rehab. Now, if you don't, so arterial AVMs can be really dangerous. Now, if you've ever had a scan for anything, they would see it. So even if they were looking for something else, they would find it. But, if you ever have headaches that are common, that you have a lot, or sometimes dizziness, or sometimes things that are happening, you might want to get checked out because these things are real. Not trying to scare anybody, but they are real. And I've seen enough young people with them that I know that they can be scary, and you never know if you have one. I do want to go through the parts of the stroke. So and this is what we call the ischemic cascade. And the ischemic cascade is kind of what happens is as soon as the blockage hits, or as soon as the oxygen, or as soon as the brain starts bleeding and the oxygen is no longer getting through, the oxygenated blood is no longer getting through. Well, you're going to have a lot of your brain cells start to freak out, okay? And they literally do. They just start freaking out, and they start dumping all this ATP and all these excitatory neurotransmitters just out into the bloodstream. Now, that's not supposed to happen, but they do that anyway because they know, hey, something's going wrong. There's not enough oxygen, or we're bleeding up here. Well, free radicals get all mixed in with that and everything. And then all that causes more cell death. So the cells freak out, release a lot of neurotransmitters that they're not supposed to, And then that, along with all the ATP that's getting dumped out, is going to kill more brain cells. So that's the second phase of the stroke, whenever more cells die. And that continues to happen until the blockage is either taken away or it moves through, or until oxygenated blood is restored back to everybody, or until into the to the person. A lot of ischemic strokes are going to cause a lot of swelling on the brain, so we call that cerebral edema. It can be pretty scary. The cerebral edema is going to basically just be regular edema, swelling that you would get anywhere else in your body, but it's on your brain. It's on, in, and around your brain, all inside your skull, okay? So think about that. That's a lot of pressure building up inside your skull, and that's not good. We only have so much room in our skull. So over the next 3 to 4 days after having a stroke, they're always doing tests to monitor your pressure inside of your skull to see how much edema you've got forming. Now, if the edema if signs of increased edema can just be increased heart rate, really increased irregular respirations. A lot of vomiting and nausea is usually a big cause. A big side effect, and pupils that are like, they'll go big and then they'll go small just for no reason. They just keep going back and forth. That's a sign of increased edema. And we'll talk about in a minute what they have to do. Well, we'll talk more in the brain injury lecture about what they do. But if the edema does get to a certain pressure, they have to go in and open the skull out and release that pressure. So they'll either bore a hole through the skull above where the pressure is, or they'll actually take part of the skull off. Okay. The other type of stroke, well, there's a couple of other types of strokes that are a little bit not as common. One is called a TIA, or trans ischemic attack, and that's what you might have heard of called a mini stroke before. Okay, so mini strokes are whenever a person starts to have signs of a stroke, but they're not very, very severe. Maybe it's just a little slurred speech and a little bit of motor weakness or a little bit of confusion, but then after about an hour or two, it completely goes away and they don't have any more signs or symptoms. They do tests on them. There's nothing wrong with their brain. There's not even an infarct in their brain. They can't even find a dead area in their brain. So it's just a transient ischemic. It means it's something ischemic event that comes and then goes. It just comes as quickly as it goes. So an example of this, like you might have not had grandparents or aunts or uncles that had TIAs. My grandmother, before she retired, had a TIA, and she was a banker, and she was working with a client, and she was counting out money or something, and then the client was the one that recognized the symptoms and said, "Hey, your voice is suddenly slurry, and your voice is suddenly slurry, and I'm having trouble understanding you." And then my grandmother had trouble understanding what the lady was saying to her. So then my grandmother was alerted that I can't understand what this lady's saying. So they were both confused. And then my grandmother stood up and then was dizzy and fell over. So they got her to the ER and then checked her out and did tests and scans. But then they were like, "Well, you're not having a stroke." But by the time they got her to the ER, most of her symptoms were dissipating. And then so within an hour or two, she was completely fine again, remembered everything that happened. But it just wasn't a full-blown stroke. So that's what a TIA is. So yeah, let's see. That's in your notes. You can read through that. So let's do this. We went about, well, I got a little bit of a late start because I was having trouble. Let's talk about the blood supply to the brain. and how that affects the stroke, and then we'll take a pretty good long break, okay? And then in that time, I can maybe fix my internet. So let's talk about what we call the circle of Willis, okay? So y'all have a video link in your folder you should have, and it should either be, I forgot what I called it. It should either be entitled Circle of Willis, or it might be entitled Blood Supply to the Brain. Either way, it's the same thing. Well, they call it the Circle of Willis because all the main arteries that go into our brain make a circle. And I know I've got a picture of that on the PowerPoint. I want to show y'all. I'm going to try to show y'all this picture. See if you can see it. Maybe it won't be too blurry. Okay, can y'all at least make out that this is an undersurface of a brain right here?
Yeah.
Yeah.
Well, I did for a second. Yeah.
Mine's still blurry.
Okay. Well, if you can see it, it's an undersurface of a brain, and it's got the arterial system there. Okay, you've got this picture in your PowerPoints, guys, and you've got it in your notes, and it's on the video links too. Okay, this is what's called the Circle of Willis, but it's the arterial supply to the blood to the brain. Okay, so I'm just gonna keep this picture up and then read off of my notes, and then y'all just listen to me as I go. But you have all these notes that I'm reading off of. Okay, so some of our the blood supply from the front to the front of the brain comes from our internal carotid arteries. So the arteries that come up the front of our neck. Okay. The back side of the brain gets its arteries coming from the vertebral arteries. So if y'all remember way back in A&P 1 and 2, I don't remember which it was, way back in A&P 1 and 2, when we were looking at the vertebrae and looking at how they look different from each other, if y'all remember, the cervical vertebrae had little foramen that went all the way up through the transverse processes, if y'all remember that. And the cervical vertebrae are the only ones that have those little foramen that goes all the way up through the cervical column. Well, that's where the vertebral arteries run through. And that's what supplies the back of the brain, okay? So let's talk about, and so they feed the there's two internal carotids in the front and two vertebral arteries in the back. And those together come together and form this massive network of arteries in our brain that supplies the whole brain, okay? Now, let's talk about those different arteries and how they, and if you can see this picture, great. If you can't see it, you'll be able to see it, make it out much better on the video or on your own slide if you're looking at it on your own. The anterior cerebral artery is coming off of, and it spans the whole front surface of the frontal lobes on both sides. And it comes off of it branches off of the internal carotid artery. Well, it supplies the medial aspect of the most of the frontal lobes and the parietal lobes. It supplies some of the basal ganglia and some of most of the corpus callosum. And if you remember, the corpus callosum is what connects the two hemispheres together. So it sounds like the anterior cerebral artery supplies a lot of blood to a lot of important parts, and it does. Okay, here's what I want you to remember about the anterior cerebral artery for a stroke. If you have a blockage of an anterior cerebral artery, you will have weakness on the contralateral side of your body, of the arm and leg. You will have sensory loss, but your leg weakness will be greater than your arm weakness. So you'll still have hemiparesis of one side of the contralateral side and sensory loss, but your leg will be weaker than your arm will be. So the lower extremity is affected more than the upper extremity with anterior cerebral artery strokes. Okay, so that's the biggest thing I want you to know about them. Okay, now if you can still see this picture, there's also a middle cerebral artery that branches off of the carotid artery. Okay, so it supplies the lateral aspect of the cerebral hemisphere. So the lateral aspects of the frontal and temporal and parietal lobes, and then some of the subcortical structures like the midbrain and the deep structures of the brain. Okay, now remember these two things. The middle cerebral artery is the most common site of stroke in the brain. So most every ischemic stroke where there's a clot or an embolus is going to show up in the middle cerebral artery. It's the most common artery that gets hit. Okay. Now, when you have a stroke in the middle cerebral artery, you get hemiparesis and spasticity on the contralateral side of the body, of the arm and leg and the face. But the arm weakness is going to be more than the leg weakness. So middle cerebral artery strokes have more arm weakness than leg weakness. And after you gain some experience, if you work with a lot of stroke patients, you'll see that's true, because you'll start realizing you have a lot of stroke patients that learn to walk again and use their leg, but then they keep that, they don't get back a lot in their involved arm. That does happen a lot. Sometimes whenever you have a middle cerebral artery infarct or occlusion, you can get some aphasia. So aphasia, and since it supplies the temporal lobes, and we know temporal lobes are where language is, we can get some aphasia, and that's problems with language, and we'll discuss that later. You can also get lack of insight of your deficits, where you don't really think about how bad your deficits are, and you try to get up and walk, and you're like, well, I know I'm weak, but I can still walk, even though you can't, and you get up and do it anyway. And you can also get field cuts with the middle cerebral artery, what we call, where you'll lose like half the field of your vision, and then you'll have black spots in your vision, and that'll happen on both eyes. And we call that term homonymous hemianopsia, or just say field cut. Much easier to say. Okay. I'm going to skip around on my notes a little bit. Now we'll talk about the posterior cerebral arteries. The posterior cerebral arteries come off of a little bit of the, they get their blood from the vertebral and the basilar arteries. So let me back up for a second. Where did this basilar artery come from? Well, I said the back of the brain earlier, this gets its blood supply from two vertebral arteries. Well, it does. But when the vertebral arteries get to the brainstem, they come together and form one big artery called the basilar artery. And it's a pretty massive artery that sits right on the underside of your brainstem. Okay. So the posterior cerebral arteries are pretty important. Posterior cerebral arteries are going to supply a lot of the midbrain, the thalamus, and a lot of the basal ganglia. Sorry, I forgot the word. So the thalamus, the midbrain, and the basal ganglia. So if you have a stroke in the posterior cerebral artery, it can cause a lot of pretty severe problems. It can cause major paralysis, like global paralysis. it can cause problems with vision where you may be able to see everything fine, but you don't know what the names of objects are. So you look at everyday objects and you may forget what they do. So you may look at its cup and may forget that that's a drinking cup. Or you may remember what it's supposed to do, but you can't remember the name that it's called cup. You just know what it's for. You also might have what we call thalamic pain, where if the thalamus is affected, you may just have a lot of massive global pain. This is real, and there's a lot of, you can go cortically blind with a posterior cerebral artery infarct, so, and go completely blind from just the stroke. So it's pretty severe. Speaking of the basilar artery, let's talk about the vertebral basilar artery strokes. If you have a stroke in your vertebral and basilar arteries, and those are the arteries that are supplying the midbrain, you're likely gonna have either you're likely gonna be, well, you will be some type of a quadriplegic. There's basically no question about that. Most people will be in a coma, if not death. So people commonly die from these strokes. And these strokes, and think about it, this is the basilar and vertebral arteries. This is controlling like our basic bodily functions, like our breathing, our heart rate, our respirations, our blood pressure. So if we have strokes here, it's a pretty big deal. So if you live through this, you're gonna be what we call to have locked-in syndrome. And this is a pretty sad and disabling disorder. You may have heard of it before, but locked-in syndrome is the technical medical term for it. It's basically your consciousness is, and your memories and your thinking are completely fine. None of that is affected. You know who you are. You've got all your memories. You know who everybody is. You've got all your knowledge, your education, who you are as a person, decision making, who you are. That's all fine. But the only thing you can move in your body are your eyeballs and your eyelids. So you can only blink and move your eyelids. Those are the only two motor things you have left. Besides breathing, you can breathe on your own and you can move your eyelids. Now that sounds like, how would you be able to even tell if a person, you would think somebody that's like that is coming out of a coma or they're in a minimally conscious state. Well, at first, a lot of those people are considered to be in a minimally conscious state, but they're constantly doing tests with them now, especially now in modern times, because we figured out what lockdown syndrome is. So they'll start having them do following commands, like, okay, with your eyes, don't blink, but follow me across the room with your eyes. And then the person can do it. And then they'll say, okay, I want you to blink twice for yes and once for no. And then they'll ask them a series of questions over and over and over. And if they get the same answers consistently, and then they'll ask them questions about themselves through eye blinks. And then they'll give them letter boards and they'll say, okay, for this letter, blink this many times. And then for this letter, blink this many times. And if they're able to spell out simple words, they'll deem them, hey, they're in there. Nurses can do that. Therapists are usually the ones that find out, hey, they're still in there. Your loved one is still locked in their brain. They just can't talk to you. They're not able to talk either. So this is a very disabling stroke if you live through a posterior basilar artery stroke. Now, don't think that you have a shorter lifespan. It all depends on how well you're taken care of. There was a neuroscientist that actually studied people with strokes, and then she had a basilar artery stroke herself. And after they discovered that she was locked in, this lady wrote a full book, her full autobiography, about her life and about having the stroke and being locked in. And she wrote about her whole experience with a communication board and just doing it through eye blinks. It took her about 3 years working every day to write the book, but she wrote it from cover to cover. And I mean, it was grammatically correct, no spelling errors, and they basically didn't have to do any editing. But if you want to look it up, it's called My Stroke of Insight. I think that lady is still alive, but she's a famous neuroscientist, and she did a lot of cool work before she had her stroke. But her book is called My Stroke of Insight, if you want to look into that. One more type of stroke I want to go back to are internal carotid artery strokes. So you probably already guessed, as I said it, your internal carotids are your main arteries coming up feeding the front of your brain. Well, if you have an occlusion in your internal carotid artery, it's always gonna affect the middle cerebral artery and the anterior cerebral artery and part of the posterior cerebral artery, okay? So think of it as your whole frontal part of your brain and the middle of your brain are going without blood and oxygen. So most of the time, people have a stroke, an internal carotid artery stroke. If they do live through it, it's going to be massive deficits, and it's going to be mixture of deficits of the middle cerebral artery and the anterior cerebral artery. So, and their deficits will be pretty bad. These people usually do die, but I have had a couple of patients that have lived through it, and I have had one patient that had his whole internal carotid artery basically just blew out one day while he was gardening, and he was in the rehab forever, but he left rehab in a wheelchair, but doing good, okay. Then I saw him for an outpatient a few years later, and he was walking. We worked for months, and then I actually saw him in town, just in the grocery store in HEB not long ago. And this guy is like a miracle. His whole internal carotid artery blew out. He should be dead, but he was walking around. Now he's got a little bit of gait deviations and a little spasticity in his hand, but can talk fine. He's all there mentally. He's gotten married since this has all happened. So he's one of those few that make it through it. All right. So let's go ahead and stop for a little bit. Oh, I didn't mean to do that. So let's stop the sharing. I'll hit record. I am now. I was recording the earlier part. I forgot to hit resume. I'm sorry. So the visual neglect that they can have, that's called left neglect, it's really, really strange. So it's more than just neglecting one side of your body and in your environment, but it's almost like not believing that part of time and space is there. So let me give you an example. I had a stroke, and you see in my chart that I have left neglect. When you come into my room to see me and I'm sitting in my wheelchair, well, I'm completely leaned over across the right armrest. My head is turned to the right, and I'm only doing things with my right arm and right leg. My left side is just over here dangling, and I'm not even paying attention to the left side of my body. Well, you come into the room and you're standing on my left, and you'd say, "Hello, Mr. Allen, how are you? I'm here to see you for PT." Well, my response is going to be, "I can hear you, but where are you?" And you say, "I'm on your left side." And I'm going to say, "I don't see you." I will not turn my head to the left to look at you, because in my head, that left side does not exist anymore. And no matter, you could get my head and force my head over to the left, and I'm going to fight you because I think you're going to make me fall. It's not a cognitive deficit, it's a visual spatial deficit. So these people these people are very difficult to deal with. You can make gains if you have neglect, but you have to do a lot of force use and stimulation and PNF and sensory stimulation to that left side before they start paying attention to it. Strategies to get over that is just always talk to them and sit on their left side. Always do things on the left side of their body so that over time they'll be forced to look at you. They even only feed them from the left side of their body so that they'll only eat from that side too. Motor recovery stages, you know, goes through all kind of stages. At first, after you have a stroke, you're pretty floppy. You don't really, no matter what kind of stroke you had, you're pretty floppy. You're pretty weak, and you're not paralyzed completely, maybe, but you just are very, very floppy and can't really move. But then in the next stage, within a few days to a week, that's when your spasticity and your hypertonicity is going to start coming into play. And those upper motor neuron lesion signs are going to start coming into play, like hypertonicity and clonus, and pathological reflexes might start coming in. Those abnormal synergies are going to start to come in. So as the next few weeks go on, those things are going to start happening. Well, the reason it's really important to get in rehab super early is because as that spasticity is starting to occur and manifest, we need to be there to help take control of it, because the longer it's there, the longer it's going to get ingrained in the brain and become part of the brain's programming and that'll be harder for us to make the brain unlearn that. Okay. So they'll be floppy and flaccid for a few days, but then they'll get spastic after about a week or so, and stay spastic for a long time. They may have some pathological reflexes. Okay. And then what are you going to do for strengthening? Well, we talked about forced use strengthening by putting them in weight-bearing positions. We talked about PNF. We talked about getting in people in different positions, like prone on elbows for weight bearing through their shoulders, quadruped for weight bearing through their arms, their shoulders, and their elbows and their hips, and then kneeling to elbow through their hips. So all of that can help get rid of spasticity, but that sends signals up to the brain to start getting to saying, hey, this muscle has something wrong with it. We need to make new pathways so we can control it and so we don't fall. Okay. Any questions about any of that so far? Okay. A couple of other motor things that happen. You can have what's called motor apraxia. Now, don't confuse this with cerebellar ataxia. Remember, ataxia was a cerebellar deficit. Whenever you go to do something, it's an intention tremor where you shake with it. That's a cerebellar thing. This is apraxia with a P. Now, this is a perceptual thing that usually is a right frontal lobe deficit. And apraxia happens whenever it's kind of strange. It's a motor thing, and it's a motor programming thing. So the simplest explanation I can think of to explain it is, say I've had a stroke, okay? And it's affecting my right extremity. And Ola is my PTA, okay? And today, me and Ola are working on reaching tasks. And Ola says, Mr. Allen, here's your coffee cup right here. I want you to pick your arm up, and we've been reaching. I want you to reach the coffee cup and grasp it with all you can and see if you can pick it up off the table and hold it for 5 seconds and then put it back down. What Ola's asking me to do, pick the coffee cup up, because she's got confidence that I've got that much strength. Well, if I've got apraxia suddenly that day, I'm going to sit there and I'm going to stare at that coffee cup, and I'm never going to move my hand. And I'm going to say, Ola, I'm trying to do it, but I know what you want me to do. You want me to reach out and grab the cup, but my arm just won't move. I could do it with my other hand, but I can't do it with this hand. Like, I can't even initiate the movement. That's what's called motor apraxia. And it's kind of strange. Well, then you, as the therapist, may be dumbfounded and like, well, I see them moving their arm every day. Why aren't they doing it now? Well, 5 minutes later, after the task is over, I'm not even thinking about what Ola was asking me to do. And I see my coffee cup there, and I'm like, oh, I want some coffee. Well, I pick my coffee cup up and I drink it with the right arm. After 5 minutes ago, I couldn't do it at all. That's motor apraxia. It's a motor planning and programming problem. And it's totally a perceptual thing. And it's really, really strange. So if you ever are working with patients and you ask them to do a movement or something that you know they can do, and they suddenly just can't do it and the movement is breaking down, that's apraxia. And there's also speech apraxia. There's also other type. There's speaking apraxia. There's other types of apraxia too, but that's motor apraxia. You're going to have people with strokes are usually going to have problems with balance and posture. We're always going to have problems with balance because of weakness on one side of the body. We're also going to have balance problems because our central balance, our balance is not just our strength in our body holding us up, but our balance is our inner ear system, and our cerebellum is our big part of our balance too. So if any part of the cerebellum gets affected, the balance is going to be affected too. So most all people with strokes are going to have balance deficits. Posture deficits are going to be big for them because think about it, if a stroke affects mostly one side of the body, then it's going to affect mostly one side of their trunk, and they're going to be leaners. They're going to, even if they can hold themselves upright, they're going to be leaning one way when they sit upright. So we have to teach them to strengthen the other side of their trunk so they can sit up in the middle. Or they may not be able to sit up at all. Maybe if they had a massive, say they had a vertebral or basilar artery stroke, but they're not still moving, they won't be able to sit up on their own at all at first. So we have to work on sitting balance activities with them. So it can be a little bit of balance all the way down to a lot of balance needing help. They're going to have speech disturbances. So, and we call those aphasia, but there's different types of aphasia. So there's fluent aphasia is also called receptive aphasia, okay? So think of the word receptive is the ability to impaired comprehension. So you can't receive the information. So you can talk, your ability to talk to others is not affected, but you have receptive aphasia. You can't understand received language to you. Does that make sense? So remember, you can't receive language or things, so it's receptive aphasia. Okay. The other type of aphasia is called expressive aphasia or non-fluent aphasia. Now, in expressive aphasia, they can understand what you are saying to them, but they might not be able to get their own words out. So they know what they want to say, they just can't get the word out or the sentence out. They may be able to get things out like in a very stuttering motion, like they may say, I need go bathroom. And it may take them 2 minutes to get that out, but they can get it out. Or they may not be able to get anything out at all, but they can understand everything that you say to them. So we call that expressive aphasia. They can't express themselves, but they can understand you. Now there's one more type of aphasia, and that's called global aphasia. That's the mixture of expressive and receptive aphasia. And that's very, very bad. So in global aphasia, the patient cannot understand any written or spoken language to them, and they cannot communicate any written or spoken language to another person. So that's very disabling, and that can make it very difficult to make any gains in rehab. Now, you can work with these people by doing lots of demonstrations. Now, when they understand, after you do a few demos and they understand, hey, I need to do this to get better, and he's demoing me this task, they'll do it. And they may need a little bit more help. They may be a little bit more, they may not have a lot of safety awareness, because if they can't understand people telling them how unsafe and what their physical deficits are because of their stroke, they may not know what they can't do. So they may be a little dangerous. So you may have to just demonstrate with them a lot, work on small little things a long time. I mean, small little things at a time instead of big movements. just until you can understand how well they can understand. And you would know that by talking to speech and neuropsych. Dysarthria. Now, dysarthria, don't get this mixed up with dysphagia. Aphasia is a problem with speech of the brain. Dysarthria is bad arth is the mouth, articulation or bad joint of the mouth. So dysarthria is just you have problems articulating your words with your tongue and with your jaw. So like it's a problem with the coordination of your mouth muscles and your tongue and your lips moving at all the same time. It's not aphasia. You understand language and you can write it out if you want to, but when you're dysarthric, you can't say the words out. Now that does all these things I'm saying but can get better over time. Everything I'm saying can get better over time. Almost everybody with a stroke is going to have some form of dysphagia. Dysphagia means trouble swallowing. That's mostly going to be with a middle cerebral artery stroke or a posterior artery stroke. These people will a lot of times after a stroke, people can't swallow thin liquids and they can't swallow regular food anymore. So they have to be on special diets. They have to be on thickened food and thick and chopped food because they can't swallow certain textures and they can't swallow thin liquids like water. They have to mix this certain powder with water to make it thicker, and thickened water looks nasty. I've seen it before. And with their juice and with their coffee, they have to mix this thickener to make it really thick, like a sludge, so they can swallow it, or they'll choke on it. And speech therapy works with patients on swallowing, but this trouble swallowing is called dysphagia. They may have a perceptual dysfunction of midline. That was one example when I told you about the left neglect earlier. They may have a perceptual problem of the perception of space, of their body in space. So they may be neglecting the left side of their environment and the left side of their body, or they may be what we call a pusher. And a pusher is a person, and it's called ipsilateral pushing, but we call them pushers. Pushers are people that have had a stroke and they're having a perceptual problem, almost always a deficit of the right frontal lobe, because that's where most of our depth perception and visual spatial deficits are, or visual spatial deficits and skills are. When you're a pusher, you lose complete awareness of your midline. So what you do, you have a hemiparetic side, but you think you're falling over. So with your strong arm and leg, you push yourself over constantly to your hemi side. So you're always leaning over and falling onto your hemi side. So these people have to be propped up. They fight you. And basically for a long time, you can't stand these people up because they will push you. They will fight you so hard, they will push you over and knock you down because their perception of midline is so far off that they're standing. This is midline to them, and this is how they want to sit and stand. Well, we know if we let them sit like this on the mat, they're just going to fall over. So we have to sit on their hemiparetic side and fight them with our body and fight them with our trunk. And we're not just telling them, oh, Mr. Smith, you're pushing yourself over. You got to sit up in the middle again. No, they think they're sitting up in the middle, and they're going to tell you, they're going to fight you physically. It's going to be a lot of work for you physically, pushing them and preventing them from falling. But it's going to be a lot of mental work for you too, to convince them that they're not falling, and for you to push them into midline and get them there. There's a lot of little tricks that you can use on the mat to try to get them in midline. The biggest thing to do is use like a big mirror to put in front of them and to let them see themselves leaning over. When we get in lab, well, we won't have a lab until after the holidays, but I'll show y'all some good pusher techniques since I'm working with pushers And hopefully some of you will get to work with pushers on your clinicals. All right, guys, just about done. They're all going to have problems with their mood. Depression is going to be the most common thing that's going to happen after you have a stroke. And that's just because it doesn't mean there's anything that a stroke suddenly made you have crazy. It just meant, I mean, think about it. If you have any medical problem that goes on with you, especially something that makes you disabled and takes away part of your independence, you're going to become depressed. Every single one of you would. And don't lie to me and tell me that you wouldn't. If you couldn't use your arm anymore, or if you couldn't walk anymore, or temporarily, you would get depressed for a little while. I promise you. Every one of these people do, of any age. And it doesn't matter how small the disability or deficit to how big it is. They're all going to be put on antidepressants at first, okay? Because we've got to keep their mood up. Because if their mood is depressed, then they are not going to be motivated to get better. And they're not going to be motivated in therapy. People that have a right hemisphere lesion tend to have more problems with their emotional functioning and regulating their emotions. So people that have this right hemisphere lesion, they tend to have more problems with controlling their sadness, controlling their happiness and laughter. They can laugh and get like uncontrollable laughter, and you can't calm them down sometimes. Sometimes they can't control, they get sad and they get stuck in a moment and they can't get off of that moment, or they get nostalgic about something and they can't control their feelings and they just talk about it forever and ever and ever. They just can't control their emotions and their feelings very well on that right side. One big thing that all stroke patients are going to have are seizures. So it's good. So if you think that you're never going to be with a patient that has a seizure, think again. It's probably going to happen to you. All people that have a stroke are at a huge risk of having seizures, because all a seizure is just an abnormal electrical impulse in the brain that can last for a millisecond or a minute. It just depends. And if you have epilepsy, you've all seen videos of people with grand mal seizures. That's pretty bad. Well, people with strokes have seizures too. They can have those types of grand mal seizures. They have a lot of seizures where they just kind of fade out, where they're just sitting there and they're talking to you and they're doing their stuff in therapy, and then they just kind of go and they zone out, and they're just like they just stop in mid-sentence. Or maybe they're just talking and then they get really quiet and then they slowly start slurring their words, and then they just go blank. They don't fall over or anything. They just stop. They're just staring there, and you're like doing like this in front of them and calling their name, and they're not responding. And then they'll just pop out of it after no time, and then they'll just be like, "What happened? Was that okay?" That's called an absence seizure, and that's what a lot of stroke patients will have. So stroke patients are going to be on a lot of seizure medication too. What just happened to minutes? There we go. A lot of them are going to have what we call a neurogenic or spastic bladder. So neurogenic bladder means they're going to have some incontinence. They're likely going to have incontinence where their bladder fills up to a point to where they never know when they have to go until it's too late. And then when their bladder's full, it just empties on its own without warning, and they go all over themselves. So they lose that control to know, like we know when we have to go, like, yeah, I need to go to the restroom, but I can wait a little while. I can hold it another 30 minutes or hour. Well, these people never get that urge to go. They never know with a neurogenic bladder. This is another upper motor neuron sign. And when their bladder gets full,
do you just tell them to go like periodically, like every 30 minutes to avoid that?
That is exactly what happens that's exactly what I was getting to. Good idea, Cheney. What we do to prevent accidents is called timed voiding. So voiding means pee. So they do this with people to help them get their bodies back to on a normal continence schedule. So they do this. This is most commonly done with spinal cord injury patients, but with anybody with a neurogenic bladder, it's going to be done. Stroke people too. So what they'll do, you'll go and they'll keep you in an incontinent brief throughout all your therapy, but you still have your regular clothes on under that. But then they catheter you intermittently every 4 to 5 hours. So they don't leave a catheter in you. They recath you every 3 to 4 hours. They take out everything that's there because that's normally about how long a bladder would last, 3 to 4 hours. They empty it. And then over time, over a few days to weeks of the bladder getting used to emptying every 3 to 4 hours, it will start getting, that will send pathways to the brain, and that will start forming new pathways for the brain to start controlling the bladder normally again. So time voiding sounds kind of bad, and painful, getting cathed over and over again every 3 to 4 hours, but it does train your body to go again on its own. If they just put a catheter in you and left it in you, then you would completely lose the ability to go on your own, and you would not be able to go on your own again. Where'd my notes go? My iPad locked. So yeah, so we have to do the time voiding a lot. Now for bowels too, sometimes they'll have bowel dysfunctions. A lot of times with upper motor neuron lesions, you'll have chronic constipation, and they have to they may have to take laxatives or suppositories a lot for a while to get their bowels used to going on a certain time system again. But once they get on a time system again, they might not need the medication again. Spinal cord patients usually do need the medication for their whole life to do it, but usually not strokes. The biggest thing that strokes people have problems in the bathroom with are the mobility problems, like with toilet transfers. And like if they're in a wheelchair, you can think, okay, we'll just transfer from the toilet to the wheelchair. But between that, somehow you've got to take your pants off and pull your pants down so you can sit down on the toilet. So somehow you've got to have the balance to do all that. And even if you're holding on to a grab bar, you're holding on to the grab bar with one hand while you're managing your clothes with the other hand while you're standing up, and you're not very good balance. So it's kind of hard in the bathroom. So we have to do a lot of bathroom training for stroke patients. So you'll do a lot of, even if you don't take patients to really go to the bathroom, train like you really are and really use their real bathroom setup to practice transfers, and get the train the OTs on the toilet transfers too, if they don't already know them, because the OTs will teach them the clothing management, how to get their clothes up and down. Because I mean, think about it. If you can transfer from your wheelchair to a toilet all day, that's awesome. But if you can't manage your clothes, then what good is the transfer? You're just going to go in your pants. So you got to be able to manage your clothes. And OT and nursing takes most of care of that. A lot of them are going to be at risk for DVTs. So they're going to have compression stockings on, things like that. Compression stockings, they'll be on medications to prevent the DVTs and blood clots for blood thinners. They're at risk for deconditioning because of just being in a bed or in a chair all day. So that's why that's our job, is to get them reconditioned no matter what setting we're in. Do y'all remember way back in semester, I think it was semester 2 in PTA techniques, we talked about something called complex regional pain syndrome? Anybody remember that a little bit?
Crips.
I see some nod. Yes, look, Crips. Yes, exactly. Well, people that have a stroke are very, very, very at high risk for developing Crips, almost all of them. So those people that have a hemiparetic side are going to, like I said earlier, they may have lack of sensation on that side, but they're also going to have neuropathic pain on that side. So we have to make sure the way that we can prevent them from getting Crips is by early mobilizing their extremities, working them out, range of motion, even if that's all they can do, putting them in weight bearing, doing PNF things with them, even if you're just doing Therex, doing as much movement as you can, as much passive and active movement as you can of those extremities are going to help prevent crips from setting in. Once crips sets in, it's pretty hard to get rid of it, and they'll probably have to have nerve blocks and major pain management for the rest of their life. Let's see what just most of what I have left now are just going to be just things that are just things for most all strokes. Now you might have heard this before. A lot of physicians will tell people that have a stroke, and not just a stroke, but other injuries too. You know, they'll say most of your recovery is going to take place in the first year. So what you get, whatever you have after the first year is what you're probably going to be stuck with. So don't assume that you're going to get much after that. Well, I'm here to tell you that that is not true. Medical science has disproven that lie many times. I've had many of my own patients before of stroke and brain injury that had their stroke and brain injury like 2 or 3 years ago, and they were coming to me with back to therapy years later with chronic problems, and I was able to help them get even better than they were before they saw me in therapy. I helped them get back some of their pre-stroke deficits. So you can still make gains after a year. They're slower. Now, it is true you will make most of your gains in the first 6 months to a year, as long as you're getting the consistent therapy. Now, if you're not getting therapy, you're not going to make gains unless you're you're going to make compensatory gains, and you won't be getting gains. You won't be making the right neural pathways. You'll be doing things the wrong way. So yes, you don't, so if somebody tells you that they're plateauing or that it's too late for them to make change, never let them believe that. Always tell them that with the right type of stimulation to the brain and the body, change can always occur. One thing, I think I told y'all about this earlier in lab maybe, you can develop what's called learned non-use syndrome or phenomena. That's just when if a person does not get the right type of therapy or does not get the right type of stimulation to their hemiparetic side, their brain is going to start unlearning and start weakening those pathways. And so there is a kind of a cutoff. So I mean, if a person went, I might be going back. Sorry, Cooper. Sorry, guys. If I went a whole year without getting any kind of therapy and I had a hemiplegic side, well, within a year, no, come here. Sorry, guys. Within a year, I'm going to be stuck in a hemiparetic contracture. And you're not going to be able to get me out of that because my brain didn't get any kind of stimulation for a year. So in that case, I might not be able to make any gains. So in that case, it might be true that I might not be able to make gains after a year. But as long as a person is you're giving their body stimulation of some type, you're strengthening them, you're working them out, you're stretching them, they are going to get some kind of stimulation. So as long as you guys are doing your job on them and making sure you're not going to just give up on them and keeping them stimulated, then you're doing your job and they're going to get better. Other typical things with strokes, they typically walk with their hemiparetic side. We call it hip retraction. They typically tend to walk with their weak side, the weak hip rotated posteriorly, which is just one of their deficits. A lot of times they have drop foot, so they don't have dorsiflexion. And they usually don't lack, they usually lose a lot of wrist flexion, and they usually lack ankle dorsiflexion. So because they're sitting in a bed or a chair a lot, and they don't have that anterior tib, so their plantar flexors take over and pull, so they lose ankle range pretty quick. You have to stretch them a lot, stand them a lot, and keep them pretty active. Other things that you don't know yet, let's see. Going back to basic thorax and knees, if they're really, really weak, and you can start them off on PNF, and then you can start them off on gravity eliminated thorax and knees exercises you learn. The same type of gravity eliminated exercises you've learned before, they work on neuro patients. Doing things in bridging, learning bed mobility, hook line things, bridges, prone on elbows, things like that. Start them on bed mobility, a lot of weight bearing, things like that. So before I ask some questions, any questions on the actual blood supply itself, as far as what arteries give more deficits to what? Because that's what I wanted you to know with the arteries. Just remember, anterior cerebral artery, if you have a stroke there, your leg will be affected more than your arm. Middle cerebral artery, your arm will be affected more than your leg. Posterior cerebral artery, it's going to get a little bit of your it's going to get arm, leg, and some of your sight. Internal carotid is going to get a little bit of everything, and you might die. And vertebral basilar artery, you will either get locked in syndrome, or you will die or have a coma. But I've got a nice video put up for y'all that you can see all that, and it explains it very much nicer than me. Okay, so now that y'all have learned PNF and lab last week, now do you start to see how some of those PNF diagonals and some of those techniques we showed you might come into play when you have somebody that has hemiparesis? Just some of those things, are they kind of clicking now? Maybe. So say you have somebody, say I have a stroke, and it affected my right side, and I'm pretty weak on that side. So you come to see me the first day, and I'm in my bed, and it's in acute care, and let's say that Shantae is my therapist. And so Shantae is going to say, hey, Mr. Allen, I heard you had a stroke. Well, I'm so sorry to hear that, but you know what? We're here to get started. It's day 1 or day 2. We're here to get started working. So she's going to look at the eval. She's going to say, I might just have 1 pluses, maybe some 2 minuses in my arm. Well, if that's all I got, well, she can start working with me. She can do those upper extremity PNF diagonals. She can do gravity eliminated shoulder thorax with me, elbow thorax. She can do some simple finger movements with me. So she could, just with 1s and 2s in my arm, even if that's the only thing I had in my whole body, she could get a whole session out of that. Even though that's not work, you might not think that's a lot of work. To a person that has those deficits, that's going to wear them out, and they're going to get tired so quick. So you don't have to get somebody sitting upright and do weight bearing every single time just to get something done. Because if they're that sick, and if they're still working on head control and bed mobility, well, you need to work on head control and bed mobility first. So work on rolling with like the rhythm dynamic reversals that we showed y'all in lab last week, or the stabilization techniques. And then you can just work on, the PNF diagonals and sideline. You can work on gravity eliminated things in sideline with Fortherex before you get up and start working on balance and things like that. So, you know, that's kind of where we are now. You know how to work with lower level patients. So, so y'all know we've had lab, so y'all know how to work with lower level patients, and y'all know a little bit about stroke. So study your stroke notes that I gave you, because it has a lot more information in detail than what I went over today. And there's some really good, those video links that I put up in the lecture folder. These are not lab videos I'm talking about. These are lecture videos, and they're videos that'll help you understand the different types of strokes a lot better. So make sure to watch those too, because I looked for those for a while and I found some that I like that'll help explain them really well to y'all. Okay. Any major questions on stroke, or any questions on stroke that you think about something I didn't mention? You're ready to start your holiday, aren't you? What if I told you we're staying until 5 o'clock today? No, I'm just kidding. No, really, we're almost done. The one thing I did remember just now that I didn't tell y'all, there is this medication that one type of stroke can take, and the whole name, I could remember the name any other time, but everybody calls it TPA is the name of the drug, and it's like the magic stroke drug. So if you're showing signs of a stroke and they get you get into the ER within 1 to 3 hours of your symptoms showing, and they do a CT or an MRI and they find that it says clot, so they find that it's an ischemic stroke, and they find the clot or the blockage, and it's within 1 to 3 hours of your stroke onset, they can give you this specific medicine called TPA, and it will break up that clot completely, and you will almost have no lasting deficits from your stroke. It's like this magic drug. But if you're having an ischemic stroke and they find your clot, but you're outside of that 3-hour window, say you get there and you're like, well, the stroke started happening 6 hours ago, it just took us this long to get to the hospital, they're gonna say, sorry, we can't give it to you. So they're not gonna be able to bust that clot. So that clot's gonna stay there and it might do some more damage. But if they gave you that medication outside of that window, it could cause massive brain hemorrhaging. So it would probably kill you. It would kill you if they gave it to you outside of the window. Now, if you don't have a clot and they find out you're having a hemorrhagic stroke, they're never going to give you TPA because it'll just make you hemorrhage even more. Okay, so TPA is a magic clot buster only for stroke, ischemic strokes where there's a clot or a blockage, and it's got to be within that first 1 to 3 hour window. After that, you're SOL. Okay. Okay, any other questions? Okay, so y'all got the notes. I'll put up this recording today. I'm sure you'll watch it over the break a lot. So our first day back at class that I will see y'all will be lab on Thursday. It'll be on Thursday. So, but we'll continue with advanced PNF. So we won't do the PNF diagonals, but we'll do so a little bit more detail on like the diagonal. I mean the PNF with bridging and PNF with rolling and PNF with bed mobility. And then we're going to get a little bit more into forced use training and then like trunk strengthening and getting trunk balance back and stuff like that. So the rest of the semester's lab skills really are not going to be diagnosis specific. They're going to apply to everybody that we're talking about. So all these lab skills we're doing now, they're just going to build on each other. So we're like everything we did last week in lab are going to be for stroke, TBI. The skills we learned for TBI are going to work for stroke. The skills we learned for MS and Parkinson's they work a little differently, but they can work for brain injury and stroke too. So a lot of this overlaps. The neuro world overlaps a lot together. So, okay, guys, I can see y'all fading, so I'll let you go.
Thanks, Mr.
Thank you,
Allen.
Mr. Allen.
Thanks,
All right,
Mr. Allen.
have a good holiday.
You too.
Thank you, Mr. Allen.